Hi, nurses from Raleigh General Hospital. This is Marla Oros. I am a colleague of yours, a nurse with the Mosaic Group, and I am delighted to be sharing this presentation and training for our Reverse the Cycle program that will be starting in the next week at Raleigh General Hospital in the emergency department to help your patients who present with high-risk alcohol and drug use. We've been working for the last almost a year now with your leadership team, with Lorinda, and with your medical director, Dr. Lane, and the rest of the team to implement this program that will provide help to patients with peer recovery coaches that will be placed in your hospital through a partnership with FMRS, your local community behavioral health center in Beckley. This program, Reverse the Cycle, is part of a statewide effort that is happening to bring this same program to another 9 hospitals across the state. You are among the 4th or 5th hospital to go live, so congratulations. And today I'm going to share with you your vital role as an emergency department nurse in the Reverse the Cycle program. So today I'm going to share with you the evidence-based SBIRT model, screening, brief intervention, referral to treatment, which is the foundation of our program. I'm going to explain the different components of the comprehensive program that we're putting in place at Raleigh General. And we're going to really focus on how this is getting implemented and your nursing role in the screening process and in another vital component that will help us respond to patients with opiate use that are coming in the hospital. So as all of you know, in addition to the national pandemic of COVID, we have another epidemic that we've often now forgotten about related to substance use. There are approximately 21 million Americans who needed substance use treatment in 2018. That's about 1 in 13 people. But unfortunately, what we know is that only about 3.7 or 17% of those Americans actually get to treatment. And so there's this significant gap between all of those individuals who are out there that have a problem and those who get help. And so we need to really do a much better job of figuring out how do we identify individuals who need help and get them on to treatment if they want it. And that's where emergency rooms become a wonderful place for us to be able to do this and where you guys come in. In 2018, close to 32 million Americans age 12 and older were just within the past month using illicit substances, and drug overdose, sadly, has now become the #1 cause of injury-related deaths in the US, surpassing motor vehicle accidents. Why we're in emergency departments, as you look at this graph, you can see since 2010, there's this very steep climb. It's not a pretty graph of opiate-related emergency department visits. And so patients are presenting, as you know, to emergency rooms when they have substance use issues. And it's not just directly, as you know, for their opiate use. These patients neglect their health. They have other comorbid medical conditions associated with their use, as well as the resulting other medical conditions that have been neglected and become acute, and then they present to the emergency department. When we look at inpatient hospital stays, we can see around the country the rates, and you can see that dark blue, West Virginia has among the highest rates in the nation for the number of opiate-related inpatient stays. And this is just looking at inpatient stays related to opiates. And so we know if we add in alcohol, which is still extremely problematic in terms of the risky use in our country and the impact on hospitalizations, we know that the stays for risky alcohol and drug use would be even higher than what this map is showing us. And so what this is really saying is that we have an opportunity with patients that are using and presenting to emergency departments and hospitals to be able to identify them, close that gap between that 70% who are getting treatment and that huge number that need it, and be able to identify them and get them the help. And the way that we do that is through this SBIRT program I'm going to talk about. When we look at the impact of the epidemic on deaths, which is really sad, and again, we look at the map and where West Virginia sits. Sadly, West Virginia is at the top of the list nationally in terms of the rate of deaths per 100,000. And when we really unpack where those deaths are coming from, and we look historically, as you can see here on this graph, from about 2008 to 2012, that top blue line is showing us that it was the pills, those prescription opiates, that was really driving the epidemic, all of those pill mills that we heard so much about. And then in 2011 and 12, as we began to shut them down, we saw the prescription pills declining. But as we know, we had lots of people who were already addicted, and that orange line is showing that climb in heroin use. As those folks weren't able to get the pills, they then turned to the street and started using heroin. And what we know now is that heroin is laced with synthetic opiates, or fentanyl, which is that yellow line, which is really so much more deadlier than heroin. It's laced in the heroin, and it's really what is driving the deaths that we're seeing currently. In Raleigh County, you can see that we have had those deaths increase steadily since 2014, with a slight decrease in 2018, but we know when we've seen more recent 2019 and certainly first half of 2020 with the pandemic, that those overdose death rates are back on the rise. And so our program that we're implementing here, the Reverse the Cycle program, has three components: that foundational screening, brief intervention, referral to treatment program, a second component for patients who are going to present with an overdose called the Overdose Survivors Outreach Program, and our medication assisted treatment initiation in the ED program. So starting with SBIRT, this stands for Screening, Brief Intervention, Referral to Treatment here at Raleigh General. As you guys know, we do lots of screening for other health conditions. And when we screen, we need to use validated instruments that we have confidence in. For this piece of it, we're going to use simple, quick questionnaires that are going to assess a patient's use of alcohol and if they're using any drugs to see whether or not it's a risky level. And then we have to talk to the patient. And that's where the brief intervention comes in. And if the patient wants treatment, we want to refer them. But instead of just giving them that piece of paper and saying, here's a list of phone numbers, we actually are going to call, make an appointment, give them the information, make sure they have transportation, and follow up with the patient to give them the best chance of getting there. SBIRT is not something that Mosaic Group or the state of West Virginia invented. It's been advanced by the Association of Emergency Room Physicians and Nurses, as well as SAMHSA and other prominent federal and national agencies. And what we know is that it works. It reduces healthcare costs in many ways you can see here. And then specifically, we know it does reduce ED visits. So how is this going to work here at Raleigh General? So as we said, it starts with this SBIRT model. And so all patients now, and I'm going to show you how we're going to do that, that present to your emergency room are going to get that screening using those questions for risky alcohol use. And that's where your role comes in. Nursing is going to do this during your nursing assessment. And once that happens, we now are going to have a team of peer recovery coaches from FMRS who are going to be here 7 days a week. It might not be 7 days right when we start because we still are recruiting for the full team, but eventually we'll have almost close to 20 hours of coverage 7 days a week in the emergency department with a peer recovery coach who will then be watching your track board, will see a positive screen, and then they're going to go have that conversation with the patient. They're going to ask you before they go in to see the patient to make sure it's a good time. They're going to go and have a conversation, bring that lived experience that they have as someone in long-term recovery. And if the patient needs treatment, they will then help make those referrals. They will also go up and follow that patient up onto the inpatient unit if they're admitted, and continue to engage and coordinate with your case managers for those referrals to treatment. So all patients, as I said, only adult patients 18 and older are going to be screened by you as a nurse at every visit. So we don't want to miss anybody, because we really want to identify those patients and close that gap. We're going to use a 3-item questionnaire called the Audit C for alcohol that assesses how much people are drinking and their frequency of drinking and binge drinking. If patients are between the ages of 16 and 17 and they present to the ED as an overdose, or you believe they're intoxicated, you can also ask the peer to see that patient. And we also are going to talk about some exclusion criteria, because we know that not every patient will be able to talk to you when they come in, but they still may need the help of the peer, and how we get that peer involved. So here is that 3-item alcohol questionnaire that I talked about, called the Audit C. And I'll show you in a moment where we get it in the MedHost system, but it's real simple. You want to ask these questions exactly as they're written here, because this is a validated research tool, and it only is effective when we ask the questions exactly as they're written. So it's real quick. We just say, how often do you have a drink containing alcohol? And you're going to click the response. How many units of alcohol do you have on a typical day when you're drinking? Or how many drinks do you have on a typical day when you're drinking? And how often have you had 6 or more drinks if you are female, or 8 or more if male? And it's cleaner I'll show you in a moment in the tool in the last year. We have 2 drug questions. In the last 12 months, did you use any illicit drugs? In the last 12 months, did you misuse any prescription drugs? Yes or no? And then if the patient says yes, we're going to click any and all of the substances. And this is how we're going to get to it. So this is, very specifically what it's going to say. So as you guys know, you have your different components of your nursing assessment in MedHost already in the system. So now you see there's an expert screening. You're going to make sure on every patient, we click expert screening, and it'll pop up alcohol use. When you click that, you'll see these 3 questions up here. How often do you have a drink? As we said, how many standard drinks of alcohol do you have on a typical day? And how often do you have 6 or more drinks on one occasion? So much more streamlined than what I just went through on that previous slide. You're just going to read them and click. And then it will give you a score, and it'll tell you here if it's positive or negative. You want to remember if we had a positive or negative, and then you're going to click drug use and go on and ask the 2 drug questions. And if you have any yes, you want to remember you had a yes for a positive screen. So as we said, there are going to be times when it's not possible for you to screen those patients, such as if the patient comes in and they're intoxicated, they are an overdose patient, either a suspected opiate or other overdose, and we know that they aren't verbal when they come in. They may not be verbal for other acute medical conditions, and we can't screen them. Very rarely does a patient refuse, as we're not going to ask the patient if they want to be screened, but if the patient, flat out refuses, then we can say that, or if the patient is in police custody. So you will have exclusion criteria, as you can see here. When you click that expert screening, as we saw before, you will also see the unable to obtain pop up. Again, this should not happen a ton. It should only happen for the reasons that you see over on the right that we just went through. If the patient is intoxicated or a suspected overdose, you want to be sure that we click that so that we can get those coaches involved. And as you can see here, the way that we're going to be able to get the coach involved is really up to you. In a lot of our hospitals, we're able to automate this based on the screening result, but MedHost would not allow us to automate it. So nurses, you guys are going to be key to this. So if you had that positive pop up on that alcohol screen or the yes to any of those questions, then you want to make sure that you place a red heart order, and I know you guys do this for other things, for a peer consultation. And you can see here that that will then pop up on the tracker board, and the peers will be monitoring that to be able to know who's positive and who they need to go talk to. And so a little bit about the peers. As I said, they are from FMRS, but these are individuals who we have interviewed. They are in long-term recovery. They are passionate. They have wonderful interpersonal skills. They have been trained by Mosaic Group extensively on how to have these conversations using that lived experience and how to function in a busy ED. Although they are going to be new to that. So we're all going to have to work together with them, but they will be 3 full-time folks that'll be in your emergency department once we're fully staffed, and 1 community coach that will focus on those overdose patients after they're discharged. So that is the screening piece. I'm going to turn now to the second piece that you guys are going to be very involved in, and that's our medication-assisted treatment initiation in the emergency department program with our fast track referral system for those patients. So these are for patients who are using opiates, who are presenting to your hospital, and those patients who are going to be seen by your peer recovery coach because they're going to say yes to the screening question that they're using opiates when you ask them, and you're going to put that red heart consult order for the peer. When they go and see the patient to talk to the patient, they will be eligible to receive an initial dose in the ED. And the reason that we're doing this is because we know that patients who want to go to treatment what typically happens now is we send them out and they can't get to a treatment program maybe for more than a day or 2 or even a week, and they go into withdrawal, they use, and they don't show up. So if we can get them that 1 dose of buprenorphine before they leave, not a prescription, just 1 dose, they leave, they don't go into withdrawal, and we have arranged for them to get to treatment the next day, the next morning, and they show up at much higher rates and they're on their way to recovery. So it's incredibly life-saving for those patients who are opiate using. So the way it's going to work is really very simple. It builds on the SBIRT program, as I said, that we talked about. Patient will screen positive after you've talked to them. We get that red heart consult, peer talks to them, and in that conversation, they're going to see if the patient wants treatment. So we're only going to refer a patient who's motivated for treatment, not a patient who says to us, oh, I just want a dose to feel better, just a patient who the peer has confirmed in their conversation wants treatment. And they will then refer this patient to your ED provider. And we've put in place a very simple MAT induction checklist that the peer will be giving to the provider that will walk them through this process. And you can see, so the first here, these first 3 bullets, as I said, the peer is going to confirm that the patient is using opiates and wants treatment and gives that checklist to the provider. And the provider's first step is to do a quick little assessment of the patient. And Dr. Lane has approved all of this, and we've done provider training at the monthly meeting on their role. The provider is going to confirm that the patient meets DSM-5 criteria for an opiate use disorder, and they're going to assign the ICD-10 code F1120 in the EMR. And then they're going to just do a quick assessment to make sure the patient does not meet any of the exclusion or cautionary criteria that you can see here. They report they are on a long-acting opiate pain medication that they're taking appropriately. Their physical exam is suggestive of significant liver disease. They have poorly controlled psychiatric disease, or they have a known allergy to buprenorphine. Most patients are eligible and do not have any of these exclusion criteria in our experience. And so once the physician or their provider approves the patient, they will then pass the checklist on to you guys. And your role is to conduct a clinical opiate assessment, or a CALS, to determine the level of withdrawal that the patient is in. And the CALS is used to be able to determine if we can give the patient a single dose of 8 milligrams of buprenorphine. If the patient scores 8 or higher, then you will notify the provider and they will write the order for the 8 milligrams of Suboxone, and you will give it to the patient. If the patient scores below 8, we can recals the patient if they're still in the ED to see if they get to the 8, or we can notify the provider and we will still make that referral to treatment, but will not give the dose. And so, as I said, the provider is going to be the first step and will assess the patient for the cautionary and exclusion criteria. And then you guys will get the checklist and do the CALS. And so the CALS is very much like a CWA scale, and it's used, as I said, to determine the level of withdrawal for the patient. And the reason that we need to do the clinical opiate withdrawal scale, which you can see you're going to get to again in your assessment by clicking CALS, and it'll walk you through the different ways that you will subjectively assess the patient's level of withdrawal and assign the score. Again, very quick, and that score will automatically add up, and this is where you see the score. If it's 8 or higher, the patient will be eligible for buprenorphine, and it will tell you that. And the reason we have to do the CALS is because buprenorphine is what we call an agonist medication. An agonist medication meaning that it works on the receptor site in the brain, the mu receptor site, that opiates, that the heroin or the prescription pills that the patient is taking also is on. And the buprenorphine actually activates that receptor site, which is why the patient does not feel any cravings or withdrawal, and why it is able to help us with treating patients with opiate use disorder. But it's what we call a partial agonist, meaning that after about 24 or 30 milligrams of buprenorphine, you can see here from the graph here that it has a ceiling effect. The patient gets no more effect from the dose compared to methadone or heroin or a Percocet, where a full agonist, the more higher doses that we give, the more effect and the more danger for respiratory depression or even overdose and death happens. So buprenorphine is, with this ceiling effect, a much safer medication. And in fact, we don't see overdoses at all with buprenorphine, which is why we can prescribe buprenorphine in doctors' offices with prescriptions, as opposed to methadone that has to be provided in a clinic. And the reason that we need to do that clinical opiate withdrawal scale is because when that buprenorphine and we give the dose and it wants to bind to that mu receptor site, if a patient came in and just used heroin and the heroin is still sitting on the receptor site, the buprenorphine is going to want to kick that heroin off that receptor site, and it'll put the patient into what we call precipitated withdrawal. And while that is not dangerous for the patient, it's uncomfortable. And so we use that clinical opiate withdrawal scale to have the patient in a little bit of withdrawal, that 8 or higher, so that we prevent this uncomfortable precipitated withdrawal. So again, that is why you doing that CALS is very important for the patient. And of course, buprenorphine is a sublingual medication. And as you guys know, you give sublingual medications all the time. If the patient is going to be eligible, they have 8 or higher, and we write that single order, no prescriptions, just giving that one dose. We want to make sure a patient has a moist mouth. We make sure they avoid any drinks before they take it, no smoking, no talking. We want to observe the patient that it's placed correctly under their tongue, it's dissolving correctly, and we instruct the patient not to swallow. And so these patients, the exciting part of this program, in addition to being able to give the patient the dose, them feeling okay, them not using, is we're going to get that patient to treatment, fast track them the next morning. And even if a patient comes into your emergency department in the middle of the night or on the weekend, we have fast track providers and telehealth providers who are available to treat these patients. And so again, across our hospitals and across the research study, we're doing this across 50 hospitals. And in the most recent, there's many now research studies. What we know is that this is incredibly game-changing for our opiate using patients. When we give them that dose, they show up to treatment about 70 to 80% of the time, compared to about 40% of the time without the dose. So again, it really is game-changing, life-changing for patients, and we can really save lives. So finally, for those overdose patients that came in, as we said, you guys will press that exclusion criteria. That will allow us to know that we have a patient in the ED, and those patients, the peer is going to refer to a dedicated full-time coach that will be in the community to follow up with those patients intensely for about 3 to 4 months, meeting them in their homes, meeting them at the shelters, at the coffee shop, wherever we can engage with them intensely to build support, build engagement, build trust, get them housing, get them food stamps, get them insurance, get them treatment. Our goal is to have these patients stay alive, not overdose, and get as many as we can in treatment. And this program nationally, once we engage, we get 1 in 3 of these patients in treatment. So we're really looking forward to bringing this program. So I'm going to summarize what we're going to do and your incredibly important role as a Raleigh General Hospital nurse. Step 1, we're going to conduct that screening of all patients 16 years and older during assessment. And so those patients, you're going to click that, remember, in your nursing assessment, expert screening, you'll click alcohol, can ask those 3 questions, pay attention to the score of positive for those 7 or higher, click the drug screening, ask the 2 drug questions, any yes will be a positive. Click the unable to obtain the screen and click the exclusion criteria, especially paying attention to the intoxication and overdose. And then the coach will take it from there. And if they are opiate using, they'll get that MAT checklist over to your ED provider. The provider will assess and they will hand the checklist to you nurses to then do that clinical opiate withdrawal scale. If the patient is 8 or higher, we're going to give that checklist back to the provider and they're going to write 8 milligrams of buprenorphine, so 8 for 8, and then we make sure that the patient takes the medication, and meanwhile our coaches are going to be fast tracking that patient next day to treatment, following up with those overdose patients and assisting with any patient who is screens positive and wants treatment with those referrals and follow-up. So thank you all. Our team, Ashlyn Martin, will be on site working closely with our peer team once we are operational in the next 2 weeks, and we'll be meeting with you and talking with you. And we are very grateful and excited to start this program. So thank you all.